Hello, welcome to Module 2. The focus of this module is professional responsibilities. I want to remind you that as much as possible, this module is going to follow the flow of your ATI book. I'm not going to cover every topic that ATI does. That's especially true if it's a topic that's covered well in another course. I want to spend as much time on these presentations focusing on things that are pretty important to the role of the nurse leader as it relates to a specific topic. So let's get started. The first concept I want to touch on is the federal law for the Patient's Self-Determination Act. It was developed in 1991. The Patient Self-Determination Act is an important act for you to know. Add it to your tickler file for NCLEX. I assure you that NCLEX is going to ask you about it. And the reason they ask about it is because it was a huge step in supporting the rights of patients and allowing them to have as much self-efficacy and autonomy in their health care as possible. So this gives you a general overview of what the PSDA does. The patient has to be informed of their rights to accept or refuse treatment. They have to first be competent to participate in their care. And then if they're competent, they're allowed to leave against medical advice. And these are the steps that ATI in your textbook recommend for if you have a patient who is leaving against medical advice. Again, first, you're going to notify the provider. You're going to make sure that the client's aware of risks, complications, disabilities, basically the logistics of, what's going to happen if you leave against medical advice. If your company or hospital has an AMA form, you're going to have them sign it. If they refuse to sign it, that's okay. You're going to document in your nursing notes that you offered the information on the AMA form and they declined to sign it. And then you're going to document the events very carefully and make sure that that's put into the patient's healthcare record. First and foremost, I want to remind you that it is always the nurse's responsibility to advocate for the client. If they make the decision to leave against medical advice, that doesn't mean that you simply unplug everything and let them stroll out the door. Give them as much access to follow-up care as possible. If your physician is willing to write some prescriptions so they have their medications, if they're willing to make some referrals to outpatient services, help the physician sort through what are possible kind of duct tape measures, things that will get that patient through until they're willing to come back and receive completed care. You don't want to just have that patient walk out without anything if there's any way at all possible, especially when you think about continuity of care, which goes back to connecting them with other providers as well as access to prescription medications. The other elements of the PSDA is it does require all healthcare agencies or organizations that receive federal funding either through Medicare or Medicaid to make sure that the patients and the staff are having conversations about end-of-life issues. And this includes asking upon entrance or admission into a hospital if a patient has an advance directive, and if they don't, to give them written instructions and answer questions they have about that. And also to talk about a durable power of attorney for healthcare. So that would be also considered a healthcare proxy. Again, these elements, the entire purpose of the Patient Self-Determination Act is to make sure that the patient is the driver of their own healthcare, making sure that they have as much autonomy as possible in making those healthcare choices. Lining up with that is the Patient Bill of Rights. There's been a lot of national discussion about what the patient's rights are, and over the course of the year, we've had lots of discussion within the healthcare community about patients' rights and then responsibilities. Originally, the conversation was about making sure that patients were aware of their rights. So there's been discussion about what those rights should look like at a federal as well as a local level. What's important to remember is that there is still no standardized Bill of Rights that comes from a federal level. Most of what is done is within hospital organizations. The idea that pushes the Bill of Rights for patients was to make the patient feel more confident in their health care and to stress the importance of how that relationship between the patient and the provider worked, as well as having the patient be aware of how they participated in remaining healthy and what their responsibilities were as part of their own health care and wellness. It's a reminder. Most of the Bill of Rights have reminders to remind the clients that they have a right to competent professional care from whomever's providing care, that they have a right to be informed about all aspects of their care, everything that goes on with them. They have a right to know about it. They also have the right to accept, refuse, or modify or request modifications for any care that's offered. And that was kind of the underpinning of the Bill of Rights, was to remind patients of these three elements that that gave them the feeling of their own autonomy and skill in driving their own healthcare decisions, and to not make them feel that there was a power structure of a physician or a healthcare team leader driving their healthcare, and that they didn't have choices and that they couldn't say no, or that they couldn't pick a provider because they had concerns about their competence, that they just had to deal with it. That wasn't the case at all. So we do know that if you look into hospital systems, that those three elements of ensuring competence of a professional, making sure that patients are informed about all aspects of their care, as well as their right to refuse any care, is clearly explained in those documents. When we think about the Patient Self-Determination Act, and we think about the Bill of Rights, very often patients aren't aware of those national conversations, those policy conversations. So let's talk about how the nurse is involved in that. Let's talk about advocacy. I think this slide gives you a pretty good idea of what nurse advocacy looks like. What I want you to understand is that that is a key and pivotal role for nurses. Whether you're a bedside nurse leader, whether you're an executive leader, really depends on who your audience is. Your job is to advocate for your patients and for your organization. Goals of advocacy are to make sure that your audience or whomever you're advocating for is well informed, that they have as much autonomy and privacy in making decisions as possible, and that they that when they make a decision about their healthcare, that healthcare decision is respected, so that we are supporting their decisions, that we're not giving advice that they're not asking for, that if they say no, and it's an informed no, we accept that as their right to choose. And the advocacy isn't influencing and forcing the patient to see things your way. Advocacy is supporting the patient having a voice, being sure that they are heard, and being the center of their own health care as far as the direction of how that goes. So the nurses' jobs are really to make sure patients have information, make sure that that they are front and center for supporting and guiding, that they directly intervene on the behalf of whomever they're advocating for, that they remember, if you're a bedside nurse leader, that your patient is who you're advocating for. If you're a nurse manager, your team is who you're advocating for. If you are if you're a chief nurse officer and the hospital is your patient or your dependent, you're taking care of your organization. Remember who you're advocating for, and do so aggressively. You also want to make sure that while you're advocating, that you're aware of social justice, that you're aware of people and populations that are being served by you as a nurse or you as a leader, that you're aware of who those vulnerable populations are, and that you keep them in the forefront. We want to be sure that when we're aware of advocacy, we talk about it on an individual level. Want to just kind of plant the bug that nurses collectively advocate very efficiently when we do it collectively. So membership to national organizations kind of collect all of the voices together and make them more powerful. So at this point in your career, you're heading into your senior year, at least most of you, think about what national organization membership looks like. And when you begin to join your organizations that are at a national level, be sure that you're joining an organization that reflects the things that you value most. Personally, I suggest that people join the national organizations of the specialty area that they are in first. So if you're going to be a pediatric nurse, go in and look at the Pediatric Nursing Association. Join their membership, and the benefits of those membership will be directly related to the patients that you're serving. Once you have a sense of what your specialty area is, then begin to look at the general organizations like the National Nursing Association. Understand that every association, not every, but most large associations have a political action committee, which is an element of that association that can be privately funded through donations and funds that come outside of the organization from its members and non-members that can drive political decisions. But in general, your general dues, the amount of membership money that you pay goes towards the operation of that organization, not political action. But that most organizations do have the political action committees as a component of them. When we work together collectively and coordinatedly, we are much more likely to influence policy and politics. And I think that's an important role of advocacy. Sometimes as bedside nurse leaders, we don't lift our eyes and remember that our voice is 3 million strong, that if we can collectively get together and we use our resources effectively, we can really change outcomes for patients. Let's talk about just the nursing values central to advocacy. 5 are listed here. I'm going to let you read them. I'm not going to read them for you. What I want to remind you is that when nurses are advocating their skills that we need to be adept at, we need to be good at. And those are the willingness to be risk takers, to have a vision, to be self-confident, articulate, or very well spoken. If we've got an idea, we've got to be able to express that idea clearly to the people we're sharing our ideas with. And then we need to be assertive. And I think we can have lots of great ideas, but if we're not brave and we're not willing to share those great ideas and we don't do it in an effective communication method, then our great ideas cannot be pushed forward. So I think those skills are pretty important. The values that are central to advocacy are carrying the value of autonomy and then respect and empowerment. And I think it's very easy for us to see that from a bedside nurse leader role of how we really want to advocate for our patients. So we care about them. We want them to be autonomous. We want them and their decisions about their healthcare to be respected. And we want to empower that specific patient to feel okay and to feel confident about the healthcare choices that they're making. If you lift your eyes a little bit and you think about what a nurse manager does, nurse managers population is the team. So the nurse manager is going to care about that team. The nurse manager is going to want to want the team to be autonomous in their decision making and how they manage their time at work. She wants the team to be respected for the work they do. And then she wants the team to be empowered to make choices within their scope of practice to drive patient care at the bedside. You just bump it up a level every time you shift the level of leadership you're looking at. What I want you to take away is those key skills and values that are essential to really effectively advocating for our clients. As we go into the patient's rights to choose and how they choose their healthcare, I just want to touch on types of consent. I'm fairly sure that you've touched on this in fundamentals, but I do want to remind you that there are 3 types of a consent, and that's informed consent, implied consent, and expressed consent. We're going to focus on informed consent because this comes under the legal umbrella of how we make sure a patient knows what their choices they're making. The nurse's responsibility in informed consent is to make sure that the patient's the patient is signing the consent. It is not the nurse's responsibility to do a lot of other things. Before a consent can be done, the person that's giving the consent, the patient, needs to be deemed competent, and that is the responsibility of the healthcare provider. They have to be able to really understand the procedure that's being performed, the risks involved. They have to be able to understand why they're having it done, what's the desired outcome, what are the expected complications and alternatives to that intervention that are possible. If you have a patient and you're not sure that they're able to comprehend and you're concerned about their competence, then that's a conversation to have with a provider, and the provider needs to take steps to work through making sure that the patient fully understands the information that the physician is responsible for giving and that they can voluntarily consent. I want to remind you who can consent. So we just talked about competence. So a competent adult can consent. A legal guardian for someone, or someone holding a durable power of attorney. So a durable power of attorney can consent for the person with whom they have that power of attorney over. A legal guardian, someone who has guardianship over an individual, can consent for that person. An emancipated or married minor can consent without an adult signature. Mature minors, and that's a legal description, it's mature minors, and it varies by state what that age is considered. And sometimes the mature minor is related to the type of procedure they're having done. They may allow a mature minor to have an elective abortion, but they would not let that same mature minor have open heart surgery. So it really is driven by varied states. So I don't want you to think about consent as only adults can do it, because there are times that mature minors are allowed to consent for specific things based on their state law. And then the parents of a minor child, and then under a court order. So those are the areas where consent can be given. So let's switch gears and talk about the three people involved, or three groups of people involved in informed consent. This is a list of the provider's responsibility. And the general summary of what the provider's responsibility is first to make sure that they're giving the information to a competent person, and then giving it to someone who's able to consent. And then they've got to tell them what's going on. All the logistics, all the things that are going to happen, the risks involved, the alternatives to what is being done, and then they have to make sure the patient has an understanding they don't have to do a procedure if they don't want to just make sure the patient has an understanding that they have a right to say no. The client's responsibility is to make sure that they're giving consent voluntarily, that they're not doing it under duress, and they're not being forced to do something. It's also the client, when possible, to make sure that they're competent, and then to ask questions. The nurse's responsibility is to be present and witness the signature. At any point during this process, the nurse also has a responsibility to make sure that the client doesn't have any other questions. And then the other piece of this is to make sure that the provider re-explains elements that are unclear. I suspect several of you that have gone through clinical, or maybe those of you that have some type of clinical or practice, have seen a provider come in and say, this is a consent for you to do surgery, and this is what we're doing, and I just need you to sign here. And then they walk out. And then the client looks at you and says, I have no idea what that person just said. Can you explain to me what they're going to do when I go into the operating room? The answer to the patient is, I fully appreciate how concerning it must be that you're not sure what's going to happen. Let me go get the physician to come in and re-explain everything, and I'll help you ask questions. You're going to empower that client to re-engage with the provider and ask good questions so that they understand. What you're not going to do is explain the procedure. You're not going to explain the risks. You're not going to explain who's going to be in there and who's responsible for what. That's not the nurse's responsibility. It is the provider's responsibility. So remember, the nurse is there as an advocate for the client and to make sure that they witness the signature, nothing else. Unfortunately, I have seen time and time again that while we know that this is within, this is policy, it's under our Nurse Practice Act about what duties nurses can perform, nurses still make the mistake of explaining procedures because the clients ask them. And the reason the client asks is because they trust and they're more familiar and they're more connected to the nurse. We want to change that way of doing things. So I want you to be mindful of that. And I want you to understand the differences in these roles. Let's touch base just another moment on the Patient Self-Determination Act. This comes under the advanced directives. You need to know, NCLEX is going to ask you, ATI is going to ask you, you're going to see it on final exams. This course is going to touch on it. But so my hope is that you're not seeing this and you're thinking, oh my heavens, I don't know what this is. So under advanced directives, the advanced directives laws are driven by the Patient Self-Determination Act. And in that goes the living will and the durable power of attorney to make sure that a patient has advanced directives that make clear what their wishes are. Living wills and durable powers attorneys are legally binding. They need to be witnessed and they need to be respected. I want to remind you that without a living will or a durable power of attorney, without a physician's order acknowledging that these are on the medical record, you do not have a DNR and you have to initiate advanced care. So if you have someone who says, well, I know that they have a living will and no one has seen it, the physician hasn't written a do not resuscitate order, your responsibility is to begin advanced life support until you are told otherwise by a physician. And my hope is that first, personally, that you have had this conversation with family and that you've done your own living will and durable power of attorney. Do not make the mistake of thinking that only people over the age of 40 need this. Everybody needs to have one. And these desires need to be communicated to the people that love you and know you well and are likely going to be the ones to make those healthcare choices for you. I'm going to throw one in that is not an advance directive. If you're an organ donor, make sure somebody knows that. Make sure that you have, if possible, that that's denoted on your driver's license and that that is communicated to the people that you love. It is, again, it's not covered under the advance directives, but it is another piece of how end of care is handled. And if we're not talking to the people that love us, it's going to be real hard for them to take care of that. Health insurance portability. This is HIPAA, folks. And I'm not going to belabor the point. I want you to be reminded that HIPAA is there. The purpose of HIPAA is to protect the privacy of health information and improve the portability and continuity of insurance and insurance coverage. The goal for HIPAA was self-determination for the patient. Just like the Patient Self-Determination Act, the idea was to make the patient the driver of who had access to their health information. And that has been hugely, hugely important. Media exposure. We're going to talk about this in two aspects. First, media just in general, nurses having an opportunity to be interviewed or seen on news channels or in a professional way to provide expertise or insight or an opinion. We don't want as nurses to avoid the opportunity to speak proudly about our profession or our employer or our organization, but we do want to make sure that whatever our hospital or organization's policies and procedures are about nurses speaking to the press and speaking to the media are clearly defined and that we understand them. The other aspect of that is to remember that social media gives us another opportunity to express our ideas and thoughts about what it means to be a nurse in healthcare. The specific aspect of social media is to remember that social media is extremely powerful and it can be an invaluable tool for sharing health information, for supporting patients' knowledge, to giving them other ways to access information about their healthcare, to communicate healthcare decisions. But it can also be very, very poorly misused. And it can be misused by the patient population, but it especially can be misused by healthcare providers, and specifically to violations of HIPAA. Accidental exposure of patient information through social media posts has become so common that there are now policies and procedures within almost every organization. There is a stepwise method to when social media violates HIPAA from an employee standpoint, that they know if this happens, then this happens with the employee. There's detailed consequences of what happens to employees who violate HIPAA through social media. Be very, very aware of your social media and what you're saying about your patients, your work, your daily experience, your employer, all of the stuff that you're putting in social media. It's out there, and even if you've deleted it, not everything can be deleted forever. And we know that people are really good at screen capturing, Snapchatting. Things show up and then they re-show up. It is especially important right now, as you are entering your senior year as nurses, that you are very thoughtful about what's on your social media, because it is not uncommon for employers to look at social media profiles and do a little background informally on who you are as an individual. So if you are working in a position and it has been your habit to go onto your social media site and complain about your employer or badmouth colleagues, those kinds of things matter to potential new employers. So be very thoughtful about how you use your social media. And my encouragement is that you use that to build up your cadre of nursing professionals and the people that are supporting you through that, and that it has a positive tone. The other piece of this to be mindful of is if there are violations through social media or any other format of HIPAA, and a nurse is aware that the HIPAA has been violated for specifically to a patient, nurses have a duty to report that. So we want to be very mindful of when we see things on social media and it has the potential to breach privacy, we want to communicate that appropriately. And first and foremost, if you see something on social media, that you notify the person and say, hey, I'm concerned about this, make sure you take it down. And then after I've had several students graduate, and every once in a while I see something on social media where they've taken a picture, it's a big group picture, and behind them is their assignment board, or there's patient room numbers with last names. And if I see it, I very quietly message them and say, hey, you got to take this down. And most of the time, guys, it's very accidental. You're not even thinking, but those kinds of things can get you into hot water. So be very thoughtful about that. Let's talk about law. Again, my hope is that this is coming back to you from fundamentals. These are the types of law. We have criminal law that covers misdemeanors and felonies. You have civil law, which are torts, and administrative law. Criminal law, think about that as violations of society. Criminal law very often can involve jail, whereas civil law violates people. So when we think about civil law, it's an injury to another that results in some kind of loss. And the loss is that person is sued to recover what was lost, either real, potential, or even perceived loss. Most malpractice cases are these. Civil law also has a lower burden of proof, and it is a real challenge for nurses when we become involved in a tort case and how we navigate it. Administrative law is the last one, and I only mention this because it's when administrative law, for our purposes, involves standards that are set by regulatory agencies, and specific to us is the Board of Nursing. So if we have a violation of policy and the Board of Nursing is involved, that comes under the umbrella of administrative law. So criminal law is when it's violating a law, so we've harmed a person or society, whereas civil law is really about the perceived loss by an individual. And the civil law almost always, maybe not always, more frequently, nurses have issues in civil law because malpractice and professional negligence ends up in this bucket. So let's move on. Nurses are at increased legal risk in the 21st century than we've ever been at risk for, and primarily because we have more authority and independence in decision making. We are no longer a job. We are a career, and we are a professional career, which makes us have more independence, and it also makes us more responsible independently of those decisions. We have increased legal accountability for those decisions. We're doing more things that used to be on the realm of medical practice. There are things that we're doing, in 2019 that we would have never done, 10, 15 years ago. We're also making more money, so we're an attractive target for someone who feels harmed by the care they were given and who feels like someone could pay for them. And the last thing is we carry, more of us carry malpractice insurance. So when you have malpractice insurance, that means that there is someone else that's going to carry a financial burden for you to cover a malpractice event. So the question is, do nurses need malpractice insurance because of our expanding roles? Are we more likely to be sued if we have malpractice insurance? The truth is the answer is very mixed. You can ask 100 different people and say, would you sue a nurse knowing that they had malpractice insurance, or would you sue a nurse whether they had it or not? Most of the time, the individual suing a nurse for malpractice at the time of the lawsuit is not aware that whether they have malpractice insurance or not. They are not aware of whether the employer is going to cover the error of the nurse, so that the employer will pay for the nurse's error. The person that's suing is often hurt and they're angry, and they're trying to find resolution to those feelings through a lawsuit. My suggestion would be, in the first few years of practice, make sure that you're carrying a malpractice insurance policy. And here's why. You are always at risk for making a mistake because you are human, and that is just life. But in your first few years of nursing, you are more likely to make a mistake because you are new. and you are learning policy and procedure, you're more likely to do something that isn't covered under hospital policy. Not because you're careless, not because you're sloppy, not because you're not a good nurse, but because you're human and you're still learning. So carry a malpractice insurance for a couple of years until you feel like, okay, I've really got this together. I'm very good with my own practice. I feel more confident. And then make a decision with your support system about whether you feel like you need malpractice insurance. Don't let the fear of being sued or not sued drive that decision, because I think there's a lot of mixed messaging about whether you're more likely to be sued or not. What we do know is that we have national organizations that talk about our insurance and the fact that we are covered. So patients have the potential to know that that possibility is out there. It's just a different conversation. Let's talk about unintentional torts. These are the results of negligence. So these are the things we do when we didn't mean to do it. So negligence is defined as the omission to do something that a reasonable person would do. It's guided by the consideration of what an ordinarily regular human affairs would do, or something that a reasonable or prudent person would do. So unintentional negligence, what we're really looking at is what would the standard of care, the regular practice of a regular person, what would a regular person have done? We're going to talk about that in a few more slides down there. I just want to plant the seed here. There's 3 Latin terms that you may see when it comes to negligence. The respondent superior, what this means is the master is responsible for the act of the servant. So that's the literal translation. So it means that the hospital is responsible for your actions as an employee if you are acting according to policy. So if you followed all your policies and procedures and a patient got hurt, let's say a patient fell out of bed and they broke their hip, and the patient and the family decided to sue. And when they go back in and they look at the event report, and they go back in and they look at the patient history and all of the things that happen, and they find that you followed the policy and procedure for patient safety, that the patient crawled over the bed rail and they fell when they did that. What this means is if for some reason the lawsuit is settled, that the respondent superior means that the hospital will pay anything that you as a nurse are responsible for paying during a lawsuit. But again, you have to be completely covered by your hospital policy, and you have to have done what you're supposed to be doing. If you didn't, you are liable. And even if you are, in a long line of suits, you are responsible for any injury that happens to a patient if you have not followed policy and procedure. The next one is res ipsum loquitur. That means that the thing stands for itself. It means that harm is obviously the result of negligence. So let's go back to the patient that fell out of the bed. If you left the patient's bed in the high position because you were doing mouth care, and then you left the rails down, and you left the call bell away from the patient, and then you left all the cords from their IV pole by the bed, and then you left their compression stockings on their feet with the slippery bottoms to the bottom of their feet, and they fell out of bed and broke their hip. Anyone that walks into that room is going to say, wow, that makes perfect sense. They were an elderly person, they fell out of bed, and it was directly related to the behavior of the nurse. That's res ipso loquitur. You're going to be in trouble. So that's very obviously you were at fault. The last one I want to mention is vicarious liability. The vicarious liability is the responsibility by association. And this is especially important when we look at nurses and certified nursing assistants. So if you have delegated a responsibility to the certified nursing assistant, and you have not followed up and evaluated the outcome of the thing that you delegated, and there is an injury to the patient, let's say they didn't turn them all shift, and by the end of the 12-hour shift they have some redness on a pressure point, you are responsible for that through vicarious liability, and you can be held responsible legally for that. So I want you to be aware of those 3 terms and understand that there are times when people are discussing unintentional torts that you may see those terminology kind of tossed around in there. The last term I want to give you is the malpractice, and that's the failure of a person with professional training to act responsibly and prudently. Very often you'll hear malpractice and negligence used interchangeably, so I want you to see them together and understand that they're pretty much the same thing. Let's talk about standards of care. The standard of care is what determines if you have breached, if you have been negligent. It is a minimum level of expertise that may be delivered to a patient. And when we look at how we establish standard of care, we look at what the accrediting bodies say. What does Joint Commission say a standard of care is supposed to be? Your Board of Nursing and your Nurse Practice Act will say, what is a standard of care in South Carolina or North Carolina or Tennessee or wherever you're from? They also look at national safety organizations, and they look at hospital policy and procedure. So across those areas, they're looking for what's the standard of care when you are providing care for an elderly patient. What would a reasonable and prudent nurse do as part of standard of care? In a lawsuit, if this actually goes to court, they're going to use an expert nurse, an expert witness who is a nurse, to articulate and establish for the court record what established reasonable care is. So an expert nurse is going to be someone that's going to be able to speak to the Board of Nursing accrediting bodies, hospital policy, as well as national safety organizations. So once they've established this is a standard of care for a professional nurse in this situation, and you've had an expert witness say this is the standard of care, then we go back and they look at what happened to the patient and did that nurse breach the standard of care. There are 5 components necessary for professional negligence. I need you to know these. You're going to see them on a test. It is not uncommon for NCLEX to hang on to these, and ATI is going to talk to you. For you to be found negligent of harming a patient, you need to have first had a duty to that patient. There needed to be a standard of care in place, which means you had a responsibility to provide care to that patient. Second, there is a failure to meet the standard of care, the breach of duty. You didn't do the standard of care, and we just talked about that in the other slide. The third thing is that foreseeable harm had to have existed, so the event can be expected. That goes back to it being very obvious that the outcome of injury to the patient was related to something you did. The fourth thing is that there has to be a relationship between the care or non-care you gave and the harm. So the action or the thing you did had to be the exact reason that the patient was harmed. And the last thing is there has to be actual injury. There couldn't have been a fear of injury or concern of injury. There has to be an actual injury. So if you are walking down a hallway and you hear a patient calling for help, and you don't go in there, and the patient falls out of bed and they break their hip, and the patient was assigned to another nurse, and so you just kept walking, but the patient in the x-ray, and they're getting their hip looked at, and they say, well, I saw that person, walking by in their green scrubs, and I hollered at that person, that nurse, and she didn't come back. You cannot be held for professional negligence because you did not have a standard of duty. That wasn't your patient. So for you to continue walking down the hallway and not responding to a call for help, it's not ethical. It's not morally right, and if I were your manager, we'd be having a conversation. But you would not be held professionally negligent for that injury. All of these pieces and parts, all 5 of them, have to be in place before a professional can be found guilty or found liable. So it's important for you to know these. It's also important for you to live them, to understand that if I'm doing the right thing for my patient, I'm following my standard of care, and I'm doing what the Nurse Practice Act tells me I can do within my scope, I'm not going to have anything to be worried about. Just some final thoughts about this. Professional negligence, be reminded that being ignorant isn't a justifiable excuse. Not having information in a situation is not a valid excuse. You have to do everything you can to be aware of the care you're providing and the risks of not providing appropriate care. That's one of our responsibilities as your nurse educators, is to make sure you're aware of what are your responsibilities and duties to patients, and for you to be able to put those things together. Under ordinary circumstance, you want to remember that the question is always whether the nurse acted with a reasonable and prudent care. That's going to be super important. Under ordinary circumstances, what would an experienced, informed nurse do? Be mindful that if you are sued, just following your physician's orders is not a defense. If a physician tells you to do something and you are aware that what they have told you to do is outside either your scope of practice, outside your standard of care, outside your Nurse Practice Act, and you do it anyway because you had an order to do so, you are culpable for negligence. So be very mindful that if you ever get a physician's order or a provider order and your first thought is, I'm not sure I should be doing this, then you need to go back to the physician and clarify, I'm really not sure that this is something I can do. If you're still not sure, you need to work it up your chain of command to get support or get clarification to make sure you're acting within appropriate duties of a nurse. The single thing we do that keeps us from being potentially sued is that we follow our state Nurse Practice Act, that we know what the Board of Nursing says a professional nurse is allowed to do within our state. A secondary piece of this, and it is secondary, is remember, people rarely sue people they like. And that is just human nature. I went to an in-service with a corporate lawyer for a hospital system, and he gave time and time again all these instances of how they were multi-million-dollar lawsuits, and a single person was pulled aside and said, this person, I don't want them involved in a lawsuit. They were specifically excluded from a lawsuit, and very often the rationale for excluding that person from a lawsuit was that they treated them nicely, that they respected them, that they were kind to them. So your first defense of not being sued is follow your Nurse Practice Act. The second defense is be nice, be respectful, use emotional intelligence, use kindness as your tool because it matters to patients. And if something goes wrong, you want to have a relationship with that patient that they're not alone in that wrong, that they're not alone trying to figure things out. So be mindful of that. Reducing the risk of malpractice. These are things that are pretty straightforward. I want you to read them. Be aware that if you are in a role of leadership, if you're a nurse manager, you have to be very thoughtful about how you approach concerns. And nurse managers, some of the big ones that they deal with when we think about things that lead to negligence, and we think about things that lead to patient outcomes that are negative, are dangerous understaffing, that we don't have the right staff credentials or qualifications to work the unit that we have, and then making sure as a nurse manager that if there are performance issues that I'm dealing with them appropriately. So those kind of the lift the eyes topics. Let's talk just for a minute about quasi-intentional and intentional torts. These are other types of torts. Quasi-intentional is the invasion of privacy. That goes back really to going into medical records that you should not be into. Defamation of character, or saying and doing things. Slander, which is spoken, libel is written. Both of those can result in defamation of character. They are quasi-intentional because very often you're doing things without due concern. You're not thinking about the harm you could be caused. So you have some responsibility in that, but there's a tone of I may not have fully thought it through with quasi-intentional torts. With intentional torts, my hope is that you see those and you go, yeah, I know exactly what those are. Assault and battery and false imprisonment. When we deal with false imprisonment, think restraints. Restraining a patient without a physician's order is going to get you in trouble. Assault and battery is going to get you fired. The Board of Nursing, I want you to be aware that these are the things that the Board of Nursing is responsible for, and that they are an administrative, they provide administrative law policies and regulations only. The purpose of the Board of Nursing is to regulate the nursing license, to monitor nursing education, to set standards for continuing education, and to discipline nurses. They're the ones that are going to set up your Nurse Practice Act, and they're going to be the ones that say, to be a nurse, these are the things you have to do. To be a nurse, these are the things you can't do. And to stay being a nurse, these are the things you must do. Part of the assignment that you'll have in this course is to make sure that you're looking at the Nurse Practice Act. And the reason we have you look at it is because very few people do. And then you get in trouble because you don't know what's on it. So anticipate that down the road. Your nursing license, my hope is that you're looking at this and think about that this is familiar for you. As a reminder, your nursing licensure, when you pass the NCLEX, notice I'm using the affirmative, when you pass, your licensure assures minimum competency, not expertise. Okay? Minimum competency. So your licensure says you are not likely to harm a patient because you have been properly trained and educated. There is a reason that associate degreed and bachelor's nurses, and if there are any diploma programs hanging around, that you all take the same NCLEX. And the reason that you do that is because you all are all working at the minimum competency level. That's what the NCLEX means. As a bachelor's nurse, we know that you're going to exceed the minimum competency, but that's not required by the state. The State Board of Nursing requires minimum competency, and that's being measured by the NCLEX. So that's the reason. It doesn't graduate, levels of novice competence. It just says, are these nurses, did they follow a standard education plan? Are they dually credentialed through their education prep? And now, are they minimally competent? Nurse Practice Act again. Just as a reminder, I just said this, make sure that the best way to decrease the likelihood that you're going to be sued is that you're following your Nurse Practice Act. And you need to know where your Nurse Practice Act is, and you need to have had some familiarity, at least be able to search it and find things that you have questions about. Common causes for professional nurse licensure, suspension, or revocation. I'm not going to read this list to you, but I do want you to be aware of the things that land on it. So spend a few minutes looking at that. Good Samaritan immunity. Generally, a nurse is not liable for injury that occurs as a result of emergency treatment provided. That the care is provided at the scene of the emergency, care is not grossly negligent, and care is rendered without pay. Just as a reminder, if you are a trauma nurse and you go up to a car accident, and the first thing you do, you find an unconscious patient in the front seat of a car, and their head is tilted at an odd angle, and the first thing you do is you pull them out of the vehicle and you drag them on the concrete, and at no point do you stabilize their spine, and they wind up paralyzed, and later down the road they find out that you're a trauma nurse and you should have known not to move a patient who's been involved in an accident, who's unconscious, whose neck is at a weird angle. The Good Samaritan law is not going to keep you out of hot water. You have to be very mindful that your care cannot be grossly negligent based on who you are. So if you are a trained nurse, there is a minimum expectation that you're not going to further harm a patient. Be very, very careful when you are in an emergency situation and you are providing care on the scene. Please know that I'm not telling you not to stop and not to help. What I am telling you is that you need to be as attentive as with good practice if you were helping in the community as you would be if you were helping while being paid. Because there are times when you can be held to that standard. Let's talk for a minute about mandatory reporting. This is something that should look familiar to you as a nurse, as a staff nurse, as a nurse executive, a bedside nurse leader, wherever your position is. You are responsible for mandatory reporting, and that includes substandard medical care, child abuse, elder abuse, and then communicable diseases. A subset of this comes under the Board of Nursing with impaired nurses, and we're going to talk about that on the next slide. The mandatory reporting to the Board of Nursing based on substance misuse has a unique umbrella, which is why it's not on this slide, but I do want you to be aware that as a nurse and you're aware of impaired nurses, there's a process in place for reporting that, and you are required, if someone is found under the influence while providing care, to report that. From a state and federal level, we're talking about substandard medical care, child abuse, elder abuse, and then communicable diseases as listed by the Center for Disease Control. Substance misuse. Folks, the big takeaway for this is to remember that as professional nurses, we are more likely as a profession within healthcare to have people within our practice that are chemically impaired than the everyday regular person. That very often when there is disciplinary action, it is secondary to the behavior related to the addiction, not the fact that the person has an addiction to alcohol or to drugs. It is something they did while trying to get the drug or while being influenced by the drug. Primary source of drugs are from our employer. It's the hospital system. And diversion, which is the stealing of drugs from your employer, is what gets you arrested, and it's how you lose your license. We've sensationalized the impaired professional, Nurse Jackie, from a nursing standpoint, and House, these remarkable individuals that do, they have these interesting lives, but are extremely disease driven. So I think it's important for us to be aware that nurses are at the forefront. And interestingly enough, if you want to look at nursing populations that are most at risk, those are our nurses who are in high stress environments. The emergency room and the ICU settings, specifically pediatric ICUs, have a high use of substance abuse. So be very mindful if you plan to work in those areas, that you need to be mindful of your colleagues, your own stress and your own response to that stress, but then also mindful of the colleagues that you're working with. 1 in 4 has the risk of being impaired. The next 3 slides are personality traits, job performance, and attendance issues that you see with substance misuse. I want you to read through these and just understand that these are the buckets that they come in. I'm not going to read them to you. You'll likely hear these again when they're covered in your psychiatric and mental health course. These are important. But for our purposes, I just want you to know that they're there. So these are the personality and behavior changes. These are the job performance changes. And these are the attendance changes. It has been my experience when I have worked with an impaired professional and when I have treated them in the healthcare setting, it almost always starts with time and attendance. It's absenteeism, lateness, unexplained absences. That's almost always the first thing that shows up on the radar. And unfortunately, I have let go or terminated employment of several employees that I strongly felt were impaired professionals, but the only way that I could discipline them in any way was because of attendance. And that is a lost opportunity for them to find recovery, as well as you're kind of kicking the can down the road because that person is going to continue to abuse or misuse substances, but they'll just do it in a new setting. So be mindful of those things. Rehabilitation plans for chemically dependent nurses follows a plan. Again, I put this in here just to remind you that if you are practicing within a healthcare setting and you are impaired or you care about a colleague who's impaired, even if you divert drugs or you come in under the influence, there can be a way back into professional practice depending on the circumstances. If you have stolen drugs and then you become legally charged with it, it's really hard to get your license back. But if you come into work and you're under the influence, you've not harmed a patient, there are steps in place, and these are the steps of recovery programs. No, again, we'll talk about this more in psychiatric mental health. It's a complicated process. And if you have a nurse who is working alongside you, who has this recovery process in place, they are some of the bravest nurses out there, because coming back from that is huge. I worked with a nurse practitioner who is actually a nurse anesthetist, and he had gotten into a drug diversion a drug treatment program, and he was under this program. He had a very hard time he got his license back, and it was under supervision. He had a very, very hard time finding a new job, and when he finally found one, he was so grateful. He was fantastic with patients, but he was very honest about how he got in the position he was in. So we want to support anyone who's struggling with addiction and trying to get their life back together, and their livelihood is within the healthcare system. We're especially vulnerable, so we want to be we want to be kind in how we handle that. Speaking of kindness, let's talk about workplace violence. I know that this has been talked to death, so I am not going to belabor the point. I know you know that it's a problem. It has been a problem since Nurse Nightingale walked the earth. We have been talking about bullying, lateral violence, incivility. It has been named so many things that it is almost comical. Leaders and peers have to deal with these kinds of behaviors immediately and at the time it happens. If we don't deal with it, either peer-to-peer or from a leadership standpoint, we create a culture that appears to allow it. It becomes pervasive. If no one says anything, it must not be a problem. It is important that we have a zero tolerance policy, but that policy means nothing if we do not have swift intervention. So the way we handle this is we directly deal with it. And that is one of our greatest failures as a professional practice is we talk about incivility, we talk about bullying, we talk about lateral violence, and we talk about it in the break rooms over, margaritas at a Mexican restaurant. We talk about it in our social media. We talk about it and talk about it. But when we see it in the workplace, how rare is it that we see the person being offended go to the person that's offending and say, this is not okay to treat me this way? How often do we see quiet conversations with people saying, well, I don't like working with that person because that they're just really disrespectful, or they say ugly things, or they make me feel stupid. And then nurse managers don't deal with it. And I see this as a real leadership failure. The reason this is ongoing is because nurse leaders don't deal with it directly. So again, just to remind you, you got to deal with it quickly, and you got to deal with it at the time it happens, and you deal with it directly. Person to person is always preferred. The person that's doing it and the person being offended is where that conversation should happen. And if that doesn't happen, then we need to elevate it to the next level. Whatever it is, we've got to deal with it. And then we need to follow our zero tolerance policy. Good old-fashioned ethics. Again, this is a familiar process. Nurses are agents of ethics. It is the core of what we do. We have a nursing code of ethics, which we'll talk about in a few moments. It is so important that we understand what ethics are, and how we're charged with supporting them. So our ethics are a system of moral conduct and principles, and they do guide us in our actions in regard to what's right and wrong in regard to ourselves as well as society. We have to know that. We look at the management of ethical responsibilities. We have to understand what ethical problem solving looks like, which we'll talk about in a minute. We have to be aware of ethical frameworks as well as our professional ethics code. These frameworks, with utilitarianism, the rights-based, deontological, as well as a duty-based and institutionalist, those are frameworks for ethics. I want you to know these. You're going to see them again and be familiar with them. I suspect you've seen these before. These are the ethical decisions and our principles of ethics. So I want you to know these. I'm going to ask them. You're going to see them on NCLEX. You're going to see them on ATI. They just don't go away. So be no more than memorizing them. Know what they look like. Know what that would look like in practice. Think about them in context of situations. Let's talk about ethical dilemmas. Ethical dilemmas are defined as making a choice between two equally undesirable alternatives. You're having to pick between two options that nobody likes. It is more successful for an ethical dilemma to be managed with an ethics committee. The more voices at the table, the more ideas shared, the better likelihood that a decision made is going to be one that isn't driven by an individual's bias or own experiences. We have lots of ways that we go through ethical decision making. My encouragement is that we use a structured approach to to managing an ethical dilemma. So we have lots of ways to do it. I'm going to give you on the next slide a mnemonic for ethical decision making. So the moral process, which has the mnemonic of kind of walking you through the steps, I'm going to break them down for you. The first step in the decision-making model for ethical dilemmas is, first you've got to make sure you've got an actual ethical dilemma. So two equally undesirable choices that have an ethical framework. Your M, which is massaging the dilemma. All that means is you're collecting data about the problem and then figuring out who's involved, and get everybody involved at the table to be involved in the discussion. The O stands for outline your options. What you're looking at there is just analyzing the pros and cons. Make your pro and con list. If we do this, these are the pros and cons. If we do this, these are the pros and cons. The R looks at reviewing criteria and resolve. So the R looks at weighing the options. So you weigh the options of all the pros and cons with the values of those involved. And when I say the value of those involved, first, it needs to be the patient and the caregivers and the loved ones, and then it needs to be the healthcare community. Looking at the pros and cons under that lens of the values of those people being involved. And then you have your A, which is affirm a position and act. And that means you're going to do something. You're going to develop a plan and then you're going to implement the plan. And your L is to look back. We're nurses. We love to evaluate. And that's what L means. Is we're looking back and we're going to think, How did we handle this? And did the outcome we thought we'd have after we did our analysis and implemented a plan, did it go the way we thought it would? And do we need to make any revisions or come back to the table and re-engage? So your L is looking back, which just means to evaluate the decision making. This mnemonic, you don't have to memorize the mnemonic. I do want you to be mindful of a structured approach and understanding that we're gonna get all the people together and collect data. We're gonna analyze the pros and cons. We're gonna weigh them based on the people involved in the decision. Then we're gonna develop a plan, and then we're gonna evaluate it. So I want you to be familiar with those steps. I like this model because for me, I like mnemonics. It helps me remember stuff. And lastly, folks, here's the ANA Code of Ethics. I want you to know the ANA Code of Ethics. NCLEX is going to ask you, ATI is going to ask you. You're going to be held to these standards. I don't want you to memorize each of the individual provisions. I want you to know that they're there. I want you to know that the Code of Ethics, the purpose of this is to help us function at the highest standards of ethical practice. Not the get by, not the minimal standard, the highest standard of ethical practice. That is the purpose of our Code of Ethics. I'm not going to read the slide to you. The other thing I want to remind you is our scope and standards for nurse administrators, which is outside the scope and standards for nurses. There's a code and standard for nurse administrators. So those are nurse leaders. There is a specific standard that specifically addresses this. That's how important it is. I think that is everything, folks. I hope that this has helped highlight some key ideas for you. Touch base with any questions or concerns.